Well, hello, everybody. Good afternoon or good morning, depending on where you are. My name is Garrett Schmidt. I am the managing editor and CEO of VBC Exhibit Hall, and I'm glad to have you with us today and like to welcome you to today's live webinar hosted by Salient Healthcare and titled The Path to Health Equity, Closing the Gap Between Policy and SDOH Actionability. And this is some really interesting stuff. I got a chance to have a sneak preview of some of the things that they're talking about. So I think you're really going to enjoy this presentation today. A few items of note before we get started. Everyone has joined today in listen only mode. So this is a traditional webinar format. You don't need to worry about muting your microphone or turning off your camera or anything like that. Just sit back and enjoy. However, we do want to hear from you, and we're going to have a time for Q&A towards the end of the presentation. But you don't have to wait until then in order to ask your question. And in fact, at any time during the presentation, if you have a question or you want to hear more about something, go ahead and ask that using your control module as an attendee. There's a place for questions specifically that's different than the chat. But go ahead and put your question there. We're going to get to as many as we possibly can today during the allotted time. If we don't get to yours, don't worry, someone will reach out to you through email afterwards, and we'll make sure to answer your question. So even if we're wrapping up at the last 5 seconds, go ahead and ask your question and someone will get back to you soon. And then finally, today's session is being recorded. So what's going to happen is when we're done, you'll receive an email from one of us at VBC Exhibit Hall, and it will have a link to the recording as well as where you can download the slides and visit their exhibit booth, which we'll tell you a little bit more about here in a little bit. But without further ado, I want to briefly introduce our speakers today. We have with us Mr. Jack Blois, and he is the General Manager of Salient Healthcare. And also we have Ms. Halit Madar Alfi, and she is the co-founder and CEO of Spatially Health. So two very impressive individuals, and looking forward to hearing from them today. Jack, I think you're going to get us started, so I'll let you kick it off now. So welcome, guys.
All right, great. Thanks, Garrett. First, I do want to thank VBP Exhibit Hall for hosting the webinar. I want to thank all the folks that are attending that listen to this important topic, and then I want to thank Halit for joining us and sharing her expertise. As you said, my name is Jack Blois. I'm the General Manager for Salient's Healthcare Division. I've been in the software solution business for over 25 years, helping deliver solutions to in organizations of all sizes, from massive government entities to 5,000 patient ACOs. I'm very happy to be here to share what I've learned. I really believe this is an important topic. Salient is a performance management company. We help organizations use data to create a culture of continuous improvement. And in healthcare, our mission is really to help organizations use data to take on more risk in value-based contracts, to confidently take on risk. Everyone's trying to get to those full risk models. And to do that, we believe you need not only deep insight into your patients and your providers, but you need the ability to share information with the right people at the right time, the old timely, actionable data. We call what we do value-based performance management, and we'll discuss how that relates to this topic a little later in the presentation. You heard Garrett say that the title of our topic today, right, is the path to health equity and closing the gap between policy and social determinative health actionability. The main point of the presentation today is what we want you to take away is that if you understand social determinants of health and how they affect your population, and you can manage them at the individual patient level, then you can address health disparities and you can help achieve the goal of health equity. So hopefully that's what you take away from the conversation today. But before we get into talking about social determinants, I want to talk a little bit about the problem. The problem that we're trying to solve for is health equity. And I just have a couple points to make here. I think that the first point is there's no question that there are disparities in inequalities across the health system. and not just areas of quality, but areas of cost, patient satisfaction. It exists everywhere. It doesn't matter whether it's across the country or in the same region or in the same network of doctors. There are people in those populations that are having different experiences and different outcomes when they engage the healthcare system. And we provide a data analysis solution, so we see it everywhere, right? No matter what the population is, you can slice the data in different ways by different demographics and see these differences. So there's no question the problem exists. It's different and it's unique in each population, and that's an important thing for you guys to take away today as well. And that means that there are many individuals that are not having a satisfactory experience. It also means that we're wasting or inappropriately spending a whole lot of resource that can be spent in other ways. So, that's the one point. The other point is the current value-based models that we have are really not designed to address these problems, right? The provider organizations like an ACO or a managed care plan, they can actually succeed in these value-based models. For example, an ACO can participate in shared savings. They can make millions of dollars in shared savings despite having all kinds of inequality or disparity of outcomes inside their populations. And a big reason for that is, think about the quality reporting requirements, right? The quality reporting requirements today are limited to just a couple of measures. They're limited to a subset of the population. They're reported in the aggregate, right, in average. So, inevitably there's going to be people that are above average and below average. So the models themselves just are flawed right now. And so it's not, hard to understand why we're having some of these, these disparities. So it's easy to understand why CMS is making health equity a priority. As an aside, it's also easy to understand why CMS is pushing for APP quality reporting. And that's not a conversation for today, but you can understand why they want to move and push to an all-payer, all-patient reporting model to help address some of the problems that we're talking about today. And that kind of brings me to, social determinants. And it's easy to see why there's so much discussion and focus on social determinants of health. It's very well understood now that social determinants are driving many of the inequalities, many of these costs. And it's clear that if we don't start to address them and manage them properly, that there's always going to be these disparities. So so today we're going to have a discussion. We're going to talk about how do you identify some of these factors down to the individual person level in your population. Talk about the sheer size of the problem or the opportunity, right? How big is this? What is it really impacting? And we refer to it as an opportunity if you think optimistically. And then we're going to touch on some of the policies, some of the costs and incentives. I'm going to move myself ahead here. Costs and incentives that we've got, that CMS has already implemented across several of these models, and then we'll wrap up talking about what providers can actually do now, how they can help manage the patients that are most affected, how we can close some of these gaps. So with that, I'm going to turn things over to Halit, and Halit, once again, welcome. And let's see if I'm on the right slide here. Yeah, here we go. So again, Halit is the founder and CEO of Spatially Health. And Halit, why don't you go ahead and take a minute and introduce yourself and introduce your company, and then you can go ahead and lead the conversation in those next couple sections.
Sure. Thanks, Jack, and great to have everybody here today. So I'm Halit Maydar-Alfi. I'm co-founder and CEO of Spatially Health. My background, I'm a trained architect with a PhD in city and regional planning. And throughout my career, I've seen how the immediate environment influences behavior, and that geomapping holds troves of latent data that can be mined to improve people's health and quality of life. Today, Spatially Health is an advanced SDOH and health equity platform that partners with healthcare organizations to identify and address those SDOH barriers. We focus solely on social determinants of health to identify and quantify the health barrier risks at the individual level and then scale that out to any segment, cohort, population, provider, market, or geography, depending on what the client's needs are and what the task is at hand. Our proprietary models leverage location intelligence and spatial analytics that go beyond the zip codes and provide granular insights at the hyperlocal level. This allows us to do things a little bit differently, but with a lot more impactability to improve outcomes, increase savings, support providers, and ultimately drive health equity. So together with my co-founder and chief data officer, Adi Siegel, and our team of data engineers, spatial data scientists, and analysts, we provide risk-bearing entities the products and tools they need to comply with changing policy demands regarding health equity and transition into that next level of value-based care. Next slide, please. So how does this actually play out when we talk about health equity and social determinants of health? What are we actually solving for? So I want to introduce you to Maria and Jennifer. Next slide, please. They're both women, age 55 years old, with diabetes and a medical history of hypertension and cardiovascular disease. So arguably, clinically, they are the same. And this is also typically how, from an analytic perspective, we really are able to, the view that we have on any patients that we're taking care of. So both Maria and Jennifer, they also happen to live in the same zip code. So really there is no distinction between them, but there's a very big difference. Next slide, please. Next. And that is that Maria cost 42% more. Next. This is because Maria lives in a food swamp, leading to poor nutrition. She has limited access to transportation, therefore misses appointments, resulting in frequent visits to the emergency room for non-urgent problems, simply because it is closer and more convenient than her provider. And Maria is just one example of how non-clinical factors such as income, education, and location impact behaviors and decision-making at the individual level, leading to higher costs, poor outcomes, and health inequities. And as you know, this is what is called social determinants of health and what is referred to as social determinants of health. So to help Maria, her provider really needs to be able to have targeted solutions. Next slide, please. So what we know, based on our research at Spatially Health, we know that about 76% of the population lives with at least one social determinant of health risk. This amounts to about $30 billion. About 62% of the population has 2 or more social determinants of health risks, increasing that to $142 billion. And there's over 37% that live with 3 or more social determinants of health risks. If you think about this, this really amounts to billions of dollars of essentially misallocated resources. And these are resources that can go towards savings, if you are a risk-bearing entity, and towards improving patient outcomes. And this is really what we're about and what we're here to talk about.
So thanks, Elite. So at this point, I would ask you guys all to ask yourselves, these questions, right? Do you know, how your own population is impacted by social determinants of health? Do you understand, the volume of the magnitude of the impact? And do you understand specifically which health barriers, right? Which specific health barriers are impacting your population in which particular specific patients? And do you have the right tools in place to understand those risks? So, those are questions you should be asking yourselves as we go forward. And while you're thinking about that, I will ask Halit to pick up, and she's going to talk a little bit now about some of the incentives and the costs and things that CMS is doing in the various VBP models.
Thanks, Jack. Please go to the next slide.
Yeah.
Great. So the big question is, why is SDOH a priority now? And as you know, we've heard of, CMS is making health equity a top priority, which will require all risk-based organizations to include measurements of equity in ongoing risk management. And we see how CMS is actually incentivizing health equity into many of its current models, making SDOH a critical component. So the following, we're going to quickly go through a couple of these models. And it's not meant to cover all the rules or operational changes that there are because there's just so many of them. but really to highlight where SDOH and health equity play a role and how social determinants of health decisions will impact financial performance. The other way of looking at it is where really are all those opportunities that we can tap into. Next slide, please. Great. So we start off with the REACH ACO, which is probably our favorite model because it's kind of the most stringent model. We consider this the canary in the coal mine because lots of experiments are going on here. Lots of really exciting things are happening here. Some of them are not easy to wrap your heads around or to be able to execute on, but very promising in terms of the direction that CMS is taking and looking at the ultimate outcomes of any one of these models and introducing health equity into the equation. So REACH ACO has basically the benchmark that is determined, but what they've added, what CMMI has added is essentially 2 adjustments to the benchmark. One is a quality adjustment, which if anyone's familiar with REACH ACO, those quality measures have been reduced to about 4 in total. And a lot of what's happening within those quality measures can be improved by factoring in the social determinants of health at the individual level, and then being able to address those health barriers that lead to the higher utilization. So there's a big room for improvement there. There's a component of health equity data reporting, which is pretty straightforward. Not the most exciting thing happening, but definitely very important, which has to do with demographic data collection and SDOH data. And then there's the health equity adjustment, which is probably the most exotic one, and that is getting a lot of attention simply because of the introduction of the ADI score, which is new to many, and the health equity plan requirements, which have short and long-term goals and ongoing reporting on outcomes. So again, something a little bit new in the equation. And the health equity plan is largely based on identifying the vulnerabilities of the aligned population and then developing a detailed plan to address them. That's the REACH ACO. Great. Next slide, please. So MSSP ACOs, for now, slowly following suit. It has a health equity adjustment component as well that works into the MIPS quality performance and also uses the ADI to identify the underserved populations, but is calculated a little bit differently than the REACH ACO. So a tiny little point there to look at if you're trying to compare the 2. Next slide, please. And Medicare Advantage. So even Medicare Advantage is not immune to health equity. So CMS is finalizing what they're calling a health equity index to encourage investments in strategies that for disparity reduction specifically. And they have measures that are going to start in 2027, with data collection happening now in 2024 and 2025. The renewed model, I should say, the Medicare Advantage VBID is also getting an additional health equity plan requirement. This is starting in 2024, where participating Medicare Advantage organizations must report biannually the beneficiary level utilization data for supplemental benefits offered under the VBID flexibility component that addresses 3 priority areas, which is food and nutritional insecurities, transportation barriers, and access to general living support, such as housing, utilizations, and such. So again, those are just like really high-level summaries of what how CMS is deploying health equity and measures of social determinants of health. And we see that there's some general themes that are emerging with understanding. Let's keep in mind that the ultimate goal for CMS is 1, to reach 100% of original Medicare beneficiaries and the majority of Medicaid beneficiaries into some type of accountable or value-based care management by 2030. Kind of feels like it's around the corner. And 2, which is equally important and sometimes gets lost, is it's really to incentivize providers to serve populations in those vulnerable communities. And that goes back to what Jack was saying earlier on, how some of these models in the past haven't quite succeeded in really what they're capable of doing.
All right, thank you. So now we're going to talk a little bit about some of the approaches and what what providers can actually do to take some action, how you can manage things that are of high quality and that would be ongoing. And I'll start. I think that the from Salient's perspective, it's still, on the same continuum, and it's still performance management or population health management for individuals, right? So the thing that you still need to be able to do to have an impact on all these folks that are impacted by social determinants is you have to be able to manage it at the individual level. And it's one thing to manage it, but it's one thing to be able to produce a general dashboard or a scorecard or monitor a group of providers' performance, but it's another thing to be able to deliver, timely, actionable data that's specific about the patient to where it needs to be. So, as I said before, that's what we refer to as performance management. And it's about, you identify, you get some information about a specific patient, about their specific needs. You need to identify the doctor that it's attributed to. You need to be able to get that information either to that doctor or to their care manager, and then you deliver it in a timely way so that that person can actually do something, and either take some action or make some recommendation that's appropriate for that person. And that sounds familiar, right? To all of us, that's been population health management and performance management for a long time. That's what we've all been trying to get to. We've been trying to get to, gaps in care analysis, right? That it's the same idea, being data-driven organizations. The Holy Grail is to be able to get timely, actionable data out to the care, ideally at the point of care, but at least to the care managers. And this is just on that same path. It's just more data. It's more enriched. It's better data, and it's more specific to some of the things that we're talking about. So to me, it's a good thing, right? It's this increased focus on health equity and recognizing that social determinants are having such an impact, and them creating all these incentives to focus on it is really a natural progression, and it's helping us, it's pushing us more quickly to where we all need to be. And as I talked about in the beginning, and Halit just mentioned a minute ago, where this is really all going is risk, right? Most organizations are being pushed or want to get to take on more risk or even take on full risk. But to do that effectively and confidently, you just have to be able to handle the data. You have to have real visibility into what's causing your costs, how are your resources being utilized. You really need to have effective attribution strategies. And what you guys are all doing now, right? You're capturing the risk, you're measuring quality. It's all the same thing, but you need to add, but to add to it, the specific social determinant data that's relevant to each patient. And if you add that to the equation, then you're going to have, the full comprehensive capability that you need to, one, manage this population, and then take on those risk-based contracts. So at this point, I'll turn it to Halit to see if you agree. If you agree that what you guys are doing is really just a natural extension of performance management.
Yeah, so let's think about the problem in kind of two different ways. When we talk about health equity and SDOH, think about it as the revenue side, right? Kind of like where CMS is putting out those models and putting the incentives to make sure that we're compliant, we're checking off the boxes and what needs to be done. But then there's the other side, which has to do with the costs, not only of the current costs that are happening in healthcare, but how do we deploy all these different interventions that address health barriers due to social determinants of health, and how ultimately do we make sense out of all that so that we stay financially viable, but also making sure that we're taking really good care of our patients, better care of our patients, and ultimately, again, CMS is focused on those outcomes. So are the outcomes of these patients improved along the way? And this is really critical because there really is no assurance that the financial incentives that CMS is providing to address the needs of the vulnerable populations will cover all these additional costs. So we need to be really smart now on how do we deploy, how do we operationalize all this, and be able to be effective in our daily workflows. And need I mention, not overburden what's already a burden system. So our approach is very different, as I mentioned before. Our approach starts at identifying the health barriers at the individual level and then matching the appropriate interventions, taking into account, the chronic conditions of the patient, the social risk context of that individual patient, if there's an ADI score in play here that we need to take into account, if the provider works in a certain way, or the provider team has certain services available, such as, a care management team or not. So all that needs to come into play when we're trying to guide the providers into what is the best course of action for their practice, for the organization, and most importantly, for the individual patients. And one of the key issues, which is kind of, doesn't come out to light too often, is, and what gets excluded, is that providers really need to see the improved outcomes within a performance year, within a certain period of time that they can take responsibility for it. And then ultimately either make the changes and make those improvements quickly so that they can adjust and be able to succeed in where they want to. So these are the three kind of components that we work within, which is we're looking for granularity, we're looking for actionability, and we're looking for impactability. And how does that come into play for us? So with granularity, one organization that we're working with, for example, is offering medically tailored meals as a health equity benefit, which is great. This is, call it a top shelf mitigation for nutritional problems in any population. So kudos to them that they're doing it. It's incredibly generous of them. But think back to the Maria and Jennifer example, where Maria would benefit from that medically tailored meal service, but Jennifer might be better served by a referral to a local farmer's market, for example, to encourage healthy eating. So where we come in is helping this organization by identifying the health barrier risks for each patient, and then matching each patient with the right intervention type so that they can strategize and plan for from a population health perspective, but at the same time address the individual patient's needs. And that is what we call a recommendation engine of one. When it comes to actionability, one of the questions that we hear a lot is, great, I have all this data, but what am I supposed to do with the information? And that is a key pain point that we hear within providers, specifically with social workers and care managers that are interacting, with the organizations that have to strategize and plan out. So now going back to the organization that's offering the medically tailored meals again, what happens when that same organization wants to move to a new area where the patients aren't affected by food deserts or food swamps? Because one of the agenda items that we have as organizations is growth. And where are we going to find that growth that is strategic and that is appropriate to our organization? So are they going to keep offering those medically tailored meals, or would they actually like to know what social determinants of health barriers are affecting that new population in order to offer the impactful health equity benefits? There's lots of them out there. It's not just food insecurity, housing, and transportation. There's several other health barriers out there that we need to be made aware of. So this ultimately comes down to issues of utilization of care and resources. So think about this. If you allocate more resources to a specific patient than they need, you're actually wasting those resources, not just for that patient, but for the patient who is now getting less resources at the same time. That does not help any of your patients, and it definitely does not help the bottom line of your organization. So, and we know that a typical ACO will have anywhere between 2 or 3 interventions that they deploy, and that's a good start. So let's double down on those interventions that are working and target the right patients, and then find out what the other interventions that the organizations might want to have to mitigate additional health barriers, right? And again, these are where the opportunities are to see where there are other potential cost savings in terms of being able to meet the needs of the patient where they are. Remember, folks, healthcare is local. It changes dramatically from even short distances. Last point, impactability. So another organization that we're working with that is much smaller and does not actually have a big care management or social worker team, and they also need to be able to get more done with less. Essentially, they have, I think, 1 worker to take care of thousands of patients, and this isn't this happens often enough. Let's put it that way. how can they still make an impact? So these risk-bearing organizations that are charged with caring for and managing diverse populations, they need to and they want to know what can they do for any given patient to mitigate specific health barriers and address with impactable interventions. They simply want to know what can they do to help their patients. And the other side of this component is that being able to track and monitor, which is also really, really important and not so easy and straightforward to do. You want to be able to see how these interventions impact utilization, such as emergency room visits and inpatient readmissions, and preventative programs like annual wellness visits and such. And this you still want to be able to do within a certain time frame so that you can get the benefits from it. And this also ties back to performance management or an analytics platform that you're currently working with, where you would track the current cost trend of that patient, and we would come and monitor over the course of, say, 6 months or so to determine if that intervention is actually impacting to improve utilization and allow costs to go down. If not, reiterate. Yeah.
All right, so I think that brings us to, really the conclusion with this last part, right, about the gap. We talked in the title, we talk about a gap between the policy and, actionability. So, can you help us understand what we're talking about here? Maybe some of the policy, some of the tools, and what maybe the conclusion is here.
Sure. So, the policy is ambitious. What CMS is putting out there of driving health equity is ambitious, but is absolutely necessary. We see it from every single perspective. But that does not necessarily let you know what needs to be done. And that's where the gap is between what the policy is setting and the tools available to actually achieve that. The brilliant part about how CMS is going about this is that they're leaving plenty of room for flexibility to allow, provider groups and individual providers to understand what works best for their patient population, and also what can that provider deploy successfully, which also needs to be mentioned. So, SDOH is not merely a bunch of buzzwords. It is a complex data-driven discipline. And CMS is approaching it as such. It demands building a fundamental data-driven workflow tool that can be monitored on an ongoing basis, one that provides the actual data for tracking and monitoring the outcomes. And many of you might already be feeling that even achieving those minimum compliance will require a sophisticated and technical approach based on data science and engineering. So ACOs do need to understand the health barriers at the individual level and be able to quickly determine what are the appropriate interventions that would best serve that patient, and have all that in the direction of achieving health equity, and being able to do so while being able to reduce costs and increase savings.
Yeah, thank you, Hilly. I agree. I think that the and again, the good news is that those organizations that are kind of on that path already, using data, using population health tools, or some sort of performance management, they're on the right path. But I think that what they're going to see when they look at their own population and look at their own data is that there are huge opportunities. There's lots of costs. There's lots of things that can really only be affected by impacting the social determinants. And as they get to these, especially if they get to full risk models, that's where the opportunities really are. Right now, they're in the shared savings models. There may be little risk, if any, and you're still in those early days where there's a lot of efficiencies to drive out and low-hanging fruit, so to speak. But as this thing moves forward and you get to these full risk models, this is the area that you're going to need to be good at, because these are the things that are truly impacting. You saw the numbers in the beginning. So, with that said, I think that we're kind of done with the presentation part. There's some more questions I would have you guys ask yourselves, right? Do you have a plan? Do you have a plan that's specific to your population? Because like we said, every population is different. can you identify down to the patient level the factors that are affecting their individual outcomes, and do you have the ability to get this information to the right people at the right time? Can you get it out to, care managers or even the providers that are responsible for those patients? Those are things you need to be able to do. With that, Garrett, I think I can turn it back to you. I think that we're done with the presentation. We're ready for some Q&A.
Wonderful. Well, guys, this was a fantastic presentation. I know I got a lot out of it. There's a lot here, to consider, a lot of factors. And we did have some audience questions that came in. If you have a question that you would like to ask, please go ahead and do that now. You are able to submit that on your control module. There's a place for questions, so go ahead and enter your questions there. But we're going to go ahead and get to as many of these as we can. I think we can. All right, first question, and these are in no particular order, of course, is what makes you different from any other pop health platform?
Yeah, that's a good question. It's a good question because there's a big distinction when, again, our focus starts at the individual level, right? And that is the basis, that's a unit of analysis in order to scale up to any single population. The ability to identify the health barriers at the individual level is critical in order to be able to match the appropriate intervention type that patient needs. So again, we're really, really smart and strategic in the resources that we're deploying for any individual, and then also being able to prioritize patients from other health barrier needs and what other interventions they may need. So it's a matter of taking the concept of the resources that are available, the needs of the patients, everything from that first mile calculation of strategically, what are we up against in terms of taking care of this population? What resources do we need in place? How do we plan for it? Do we have all the services that we want in place, all the way through to making those daily decisions and ongoing decisions on the care management side when they're actually at that point of care, addressing those specific needs.
Great. All right, next question here is, why can't we just use the ADI score / SVI score to satisfy the requirements?
Yeah, so let's start with the ADI score. The ADI score is a very sophisticated and very important index that CMS is bringing online. We first started with the REACH ACOs. ADI is used in a couple of different ways, right, for a couple of different reasons. One is to be able to have a high-level view of any population in terms of where are what's considered vulnerable populations, whatever ADI scores is calculated, and then where, from a revenue perspective, CMS is coming on and saying, okay, we're going to incentivize providers to move in and to serve into some of these vulnerable communities, understanding that additional resources may be needed, most likely are needed, and should be put into those communities in order to improve the health outcomes of those individuals. So it's a way for CMS to measure and to allow the providers to know what are the populations that they're actually covering. But then also from a revenue perspective, those that are in REACH ACO are feeling this. Those that are not, it basically comes down to the top 10, the top decile, to the top 10%, actually 9%. Of the population is what's considered vulnerable and gets an additional $30 PMPM. The middle section, which is about 40% of the population, is neutral, but then the bottom 50% is actually penalized with $6 PMPM. So the revenue side kind of changes a little bit. Now, why can't you use just the ADI? For two reasons. One is it doesn't tell you what you actually need to do to mitigate for those health barriers that the patients are up against, right? So that's an important part. The other part is, when you're trying to make sense in your organization, how do you serve all of your patients? The fact that a patient lives in a high ADI score does not necessarily mean that they have, significant health barriers or high health barriers. Conversely, not everyone that does not live in a high ADI score does not have health barriers, meaning there are plenty of patients and population members that are still impacted by health barriers, and they need to be identified, they need to be addressed so that you can approach them from a mitigation perspective, intervention perspective, be able to provide them the services and improve their health outcomes as well.
Wonderful. Okay, next question here is just says, what data do you use? I'm not sure if you know what that's referring to.
Am I getting all the questions? So,
Yeah.
Okay. So what data do we use? A couple of different data. So first of all, we start off with the same data just about anybody else starts, right? We have CDC data, CMS data, census data, you know, any other publicly available data that could be leveraged here, we include. We also, because our platform is a bit of a, you know, a bottomless pit in terms of the data that it can take in, we also leverage the claims data from the client, but then also if the client has any other additional data that they want to include, as this directory data, if it's data from, you know, an app that they have, we can also include that as well. But and then on top of that, there's also some license data, but that's nice and good. But really what happens is that we model all of the data, so we actually end up working off of the derivative data that we're able to generate from all those different data sources to give us a full coast-to-coast view and a continuous view of what's happening in any market. And there's lots of benefits to them. One critical one is that you can literally compare apples to apples. So if you codes are not an appropriate unit of analysis when you're really trying to understand what's happening at the local level. We know that in any zip code there can be, you know, drastic differences from, you know, one corner to another, and unless you're really able to pick up the hyperlocal component of what's happening, you're going to miss on a lot of the finesse of what's happening, and you're just basically going to be working off of high averages, which is not helpful enough.
Yeah, but I would answer that question. You know, in the healthcare space, you know, we've predominantly focused on the claims data, you know, the EMR data, the clinical data. It's one of the reasons why, you know, we've been attracted to Spatially is, you know, because our focus is to take all that other information that we get and create that really detailed, actionable, you know, specific information. And they do the same thing, but just with, you know, with a different, you know, with different sources. And you know, speaking of bottomless pits, right? You know, we can, you know, our scalability and, you know, is really the calling card for Salient is that we can bring all that data together into a single platform. So once it's, you know, aggregated, once they've run it through their algorithms, once they've created, you know, the individual pieces for each patient, then it's, you know, then it's shared with our system, paired up with, you know, the historical data that we provide. And as she talked about earlier, and you know, the granularity, what was it? The granularity and actionability and what was it? Impactability. Impactability is really measuring the impact, right? So it's really about, did it work? What happened, right? And that's really where our platform comes in. You can see, you know, did it move the needle? Is the experience been different for that particular individual? So that's where we're at. So
yeah, that's all. Yeah, go ahead. Yeah, we do have a few more here. Next question here is, I think you'll like this, is how do we avoid the medicalization of risk factors when we know that medical systems are often the most expensive sites to receive care? Aren't we throwing away medical dollars, or I'm sorry, aren't we throwing medical dollars and creating a profit for healthcare companies for, quote, solving problems that can be traced back to poverty? I don't know that there's a great clear answer for that one, but see what you guys have to say.
Yeah, I would say that usually the answer to any of those kinds of questions is visibility, right? When you have enough information to really understand what's going on in a population. So even if, even if the intervention is something that doesn't make sense, like they're talking about something that now we've medicalized it, we've made it more expensive than it needs to be. It should, if they have enough information, it's not in that organization's best interest to overspend, right? They should be looking for the most effective, the most cost effective, because they're, especially if they're in a risk-based model, it's going to be in their better interest. They're going to be on the same side of the table, so to speak. So, to me, the answer is always more information and more and better, and deeper insight and true transparency. I don't know if you've got a different answer to that, Halit, but it is risk, and and I think that the other point that Halit made earlier is a lot of folks think they're just going to do one size fits all. They're going to throw, they're going to do an initiative, a handful of initiatives for their whole population, right? And she mentioned earlier, you can't afford it. There aren't enough resources to go around, and that's why it's so important to be able to pinpoint the specific needs of the specific patients, because you can't just spread the whole thing like peanut butter, and you can't do the most expensive thing. You need to do, the whole idea here is to not just improve the satisfaction of the patient and the outcome, but also to manage cost, right? It's all part of the same effort.
So, but if we take a step back, what is happening largely in healthcare is that we're dealing with really big and deep social problems, and they've existed for a long time. It's just that magically it's coming up on healthcare's books, meaning the fact that people don't have proper nutrition is driving the healthcare costs. The fact that they don't have access to the providers that they need is driving up healthcare costs. The fact that they are choosing to go to the emergency room over being able to be seen on a more regular basis at a clinic is also impacting the costs and the outcomes. So it is a bigger problem than healthcare can address. Specifically for that reason, we're trying to take this big problem and whittle it down to what can providers actually do within their organizations, something that is manageable, that is controls for the quality and also for consistency, because ultimately they're the ones that need to answer for the costs that are incurred by it, and hopefully get to, with the goal of getting to improving the outcomes of the patient. So that's kind of like an odd reality that we are right now. Information is key in order to know what is the best thing to do. How do we go about in prioritizing the dollars that we can put into a community? How can we improve those costs without, again, spreading it thin like peanut butter and almost wasting certain resources, but being very strategical and targeted into understanding who are those patients that need very specific services that might cost more and might cost almost nothing. So, and that's where, our library of interventions is a lot broader than, getting a ride share, or if it's telehealth, which are really, really important solutions to very specific situations.
Yeah, no, I think that's a fantastic answer. And I think just having this dialogue is a step in the right direction, right? I mean, now we're talking about it, now we're focusing on it. Now it's become a real and important issue. So I think that we're making headway, slow as it may be, in the right direction there. Okay, next question here is, how do you determine what resources are available for a certain population?
Lots of different ways. So
pretty broad. Yeah.
Some of the resources are, community-based resources that, we're hearing a lot of lately. Some of it is resources that are more universally available, that are not necessarily, locally based. It's really a matter of tailoring to that provider organization. What are they good at? What are they currently doing that they can double down on? And then understanding what services potentially are missing, so that, reflecting on the patient needs, how could they introduce those services, again, that don't necessarily, need to be expensive or be solely a referral to community-based organizations, but there's lots of other services that can be introduced. You know, half of the solution is in understanding what the problem is. And if we can get a really good handle on what the problem is, finding solutions for that is much easier.
Yep. Yeah, and obviously, and the solution resides in lots of places, right? Like you said, the community-based organizations, the payers themselves are looking at different benefit models. You know, things that they haven't traditionally paid for, that they're willing to pay for now, or they could be convinced to pay for now. So, you know, that's a deeper conversation that you're going to have with your network. But to Halit's point, you know, if you can show them, hey, look, we know that this is the problem. We know these are the things that are driving, you know, the disparities and the poor outcomes, then you're going to have a much better opportunity to get what you want.
Yeah, very good. Next question here, keeping it rolling, is are there certain models of intervention that are proven to increase value for patients who have been identified as having suboptimal social determinants of health? You may or may not have already touched on that or answered that. Forgive me if that's repetitive.
So I can say this, a couple of things. One is, depends on what timeline you're looking for. If you're looking for something for timeline, we know that medically tailored meals, and this is why we kind of drive it hard, because it's like a key example of what works for particular patients. You know, that's a matter of just understanding and being able to identify what is going to work, you know, again, from a short-term and from a long-term perspective. In all honesty, the industry is learning how to deal with this stuff. Nobody has it fully understood, buttoned down, know it to go, and, you know, all systems go. This is going to be a process. It's going to be a process that we need to iterate on. We're going to learn new things. We're going to fail sometimes. But this really is the best way and the fastest way to go forward. And the only thing that we can encourage is, don't try to take shortcuts. The fastest, cheapest way is to do it right the first time around. And we're you know, minimizing the amount of iterations that need to have by being able to identify very clearly what those health barriers are, so that we can address those specifically and not the ones that are, you know, in another county or someplace else, just because that same type of patient, you know, for example, a diabetic has, you know, tends to be in a certain area. We don't know that for sure. We want to make sure that we understand fully at the context of that individual level what's going on and address that. So it's almost like the holy grail of what, you know, healthcare really wants to be, which is, you know, personalized, you know, benefits at the individual level. Crazy.
Yeah. Yeah. And then I think the last question, unfortunately, that we have time for, and we do have some more questions that came in, so really appreciate everyone's participation. If you have a question that you still want answered, go ahead and ask it, because someone will reach out to you through email afterwards. But the last question that we're going to ask today is there a plan for medication reduction?
I think that's a clinical question that needs to be asked.
Yeah, I don't know that I can answer that question.
Okay, well, yeah, that may be one that you might want to clarify and resend to us. But I will finish with this. If there is, if someone wants to send an RFP, what would be the best way to go about doing that?
I think it's contacting us directly for starters. I think our contact information is here. We're obviously on LinkedIn. You can check out the website. So yeah, I mean, for us, you can contact me directly, and I'll.
Okay,
yep,
great.
The same here. I can get you routed to the right folks. Yep.
Very good, very good. Well, thank you both so much. This was a wonderful presentation, and as we close out, I wanted to encourage you to go visit the Salient Healthcare exhibit booth, which is a virtual exhibit booth at vbcexhibithall.com. And there you can interact with their team. You can kind of get a snapshot of what they're doing in the value-based care space and do a drill down in a deeper dive into their solutions. and there's a lot of great resources there. So definitely go check that out. There'll be a link in the slides to where you can reach that directly. And then finally, again, as they just mentioned here, if you'd like to reach out to either of our speakers today, their information is here on the slide, and it will also be in the slide set that's available for download here soon. Please reach out to them, or feel free to reach out to me as well. I'm happy to facilitate an introduction, and I'm sure they would love to continue the conversation. So thank you again to everyone who attended. Really appreciate you spending your afternoon with us, and we look forward to seeing you on the next webinar. So thanks for coming. Thank you, guys.
Thanks, Garrett. Thanks, everybody. Thanks.
Bye-bye now.
Bye-bye.